Actually, you need a jacket in India now because it's too cold. The air conditioning is leaking.
26, my daughter. Son is 25. Youngest daughter is 20.
Good evening, ladies and gentlemen. We will start the program. I'd request Dr. N.S. Murali, Honorary Secretary and Chief Surgeon of VHS Medical Center, to welcome everybody. Thank you.
Good afternoon to all of you. Before I say welcome, may I request all of you to put your cell phone in silent mode so that we don't have disturbance during the oration. All of you are aware that this has become an annual affair, which is an event which is looked upon and awaited by many of the elite, the medical profession and the lay public of Madras. It has become a prestigious oration as far as the neurology and neurosciences goes, and we at the VHS and its founder Dr. K.S. Sanjeevi have always been at the service of the community and to deliver the best that is needed for the community, and in the same process also give the best to the medical profession so that they can serve the community well. These interactions and various programs that are being run are in this spirit of Dr. Sanjeevi's founding of the VHS. As you are all aware, the family of Chima and the TVS group have always been a very forward-looking family, and they have always helped causes, whether it be education or health, in a big way. And this annual oration endowment is made possible because of the munificence, should I say, of the family of TS Srinivasan. And I have the great pleasure in not only welcoming Venu, but also Mrs. Srinivasan, Mallika, Balaji, Malu, and other members of the family of TS Srinivasan who have come here for today's function. We have the expertise, we have the medical group to get on and do things, but without the cooperation of groups like the TVS and various other philanthropic individuals and industries, VHS won't be what it is today, and we were able to hold our head high and celebrate 50 years of founding of VHS early this year. So we all know the amount of work that has been put in by the various people, all of them putting in honorary work to get VHS to what it is today. Coming to the speaker of the day, I did not go into his credentials. He is a well-known people, and we are happy that the department and E.S. Krishnamurthy have been able to get regularly in the various speakers for this program. And we are thankful to you, sir, for accepting the invitation and coming, and I welcome you on behalf of all of us, and in particular the Department of Neurology at the Voluntary Health Services. No function can be a success without the participation of the audience. And this lecturer in particular is unique in that way. We have the medical fraternity and the laity, if you can use that term, who are able to mingle and listen to the various aspects of neurology that are unfolded to them. And I perhaps say that these lectures are made, many of you are attending this lecture very regularly, are better neurologists than some of our neurologists, and maybe has made the life of many of the neurologists a little difficult because you seem to get to know more of neurology and what they have got to know. And I welcome all of you for this function. And many of us in the audience, including myself, are all in the age group of the topic which Professor is going to talk about, and we are looking forward to what he says about the aging and the brain and the disorders. I once again welcome the dignitaries on the dais, the family of Srinivasan, and all of you for this function. Thank you.
I would now request Dr. E.S. Krishnamurthy, Director, TS Srinivasan, holding the TS Srinivasan Chair and Senior Consultant, Institute of Neurological Sciences, VHS, to introduce this program.
Mr. Vendra Srinivasan, Professor Morris, Dr. Murli, Dr. Krishna Srinivas, dignitaries of the dais, ladies and gentlemen. It's a great honor and a pleasure to stand before you today. And the topic of today's oration, the aging brain, is extremely contemporary for all of us. Let me highlight why I think it's contemporary from the Indian perspective. We have a population of elderly that is growing. And globally, the population of people with dementia is 24 million and over. And by 2040, we will have over 80 million people with dementia around the world. But in this period, between now and 2040, the growth will take place in countries like India and China, where people are living longer and longer. And to illustrate the nature of the growth, it will be 300% in India and China. So we're going to have an explosion of elderly people, an explosion of dementia as a clinical condition. As a doctor, I know that most of my patients with dementia are looked after by their families. So we have an additional problem. Our family structures are changing. Older people are living alone, having to fend for themselves, being looked after, no longer supported by the informal caregiving systems that we are taking for granted. It's not worrying to me that we take those family systems for granted, but it's worrying to me that the government takes those family systems for granted as well. So the burden of looking after people is therefore left with the families, and the family systems are crumbling. So it's frightening to think what will happen 10 years from now, who will look after the older person with dementia. And I think that is what puts this whole thing in context for us today. There are other factors. The 1066 project, for example, was set up with a view that while 66% of dementia is in developing countries, only 10% of the research happens in developing countries. And yet we have many unique aspects that need to be studied systematically in the developing world. And this collaboration that we now have with the National Brain Research Center, for which we are truly grateful to Dr. Ravindranath, the director who's here, is something that will help us study at a national level, hopefully, why dementia is unique in this part of the world, why aging is unique in this part of the world, and what unique factors exist, not just social factors, but also physical, biological, psychological factors that exist, because that is what is going to give us original ideas to think about what we will do to prevent disease progression, to diagnose people early, and protect them from disability, because conditions like dementia do confer very significant disability on all of us. And this program, which is organized together with the National Brain Research Center, has two components. We have a 2-day workshop here in Chennai with people from all around the country taking part, trying to develop a national research program. And then we're very privileged that this year we have a program in Delhi, which will be a conference on the aging brain and mind. And there's a 2-day program that follows this one. So I think it's very, very great pleasure this time to introduce the program because it's unique, different, but is also on a very, very topical issue. And I won't stand between you and the orator. Thank you so much.
I now request Mr. Venu Srinivasan to give the presidential address and present the award to Professor John Morris. Thank you.
Thank you, Dr. Srinivas. Professor John Morris, Dr. Krishnamurti Srinivas, Dr. Murali, and Dr. E.S. Krishnamurti, and ladies and gentlemen. It's a great privilege actually to stand every year before you not because of all of us, but more because of the eminent guest speakers that we have been fortunate to have year after year. It is, Professor Morris, the visit of professors like you that have elevated this lecture to one which is followed nationally and internationally as a very serious program on neurology in India. We started this program 30 years ago when, 29 years to be exact, when my father passed on 30 years ago, and Professor Krishnamurti Srinivas then came to us and said, look, with your father's interest in neurology and medicine, the one thing that the family could do was to support a program to bring world-renowned experts in neurology and share the knowledge with doctors in India and students in India so we can give a fillip to the growth of neurology in this country. My father's association with Dr. Srinivas goes back a long time, and the reason Dr. Srinivas came with this was he was a great supporter of the social medicine, of community medicine, and particularly because he had a large number of employees in the welfare of his employees and their families. His interests were quite varied from technology to management, but he had a particular interest and keen interest in medicine and advances in medicine. And that's how this program came about. Over this time, we are really happy and gratified to see the developments in community neurosciences that the center has helped engender. The center began with a clinical care provision and public education focus, and now with Dr. Krishnamurti, E.S. Krishnamurti's dynamic leadership, it's become a major hub for community-based professional training, neuroscience research, and health and policy development. It attracts students not only from India, but internationally as well, and it's indeed befitting that this center should be located in an eminent institution which Dr. Murali is the Honorary Secretary of, which was founded by late Professor Sanjeevi, who was a great giant and a pioneer in the field of community health at the Voluntary Health Service. The VHS hospital today is a mother NGO for a number of important national healthcare programs, and we are very grateful to Dr. Murali and the trustees of VHS for helping house the department, the TS Srinivasan Department of Neurology, and provide it with consistent support and morals as well as physical support. The TS Srinivasan Center for Clinical Neuroscience and Health Policy at the VHS in Taramani has an active group of research students and workers in various fields of neuroscience, epidemiology, outcomes research, clinical trials, imaging, patient care-centered research, and health policy development. The fellowships hosted by the center include those supported by prestigious organizations and international collaborations with renowned world universities and research organizations. They've done a lot of work on things like quality of life and stroke, epidemiology of dementia, epilepsy and stigma, student mental health and academic performance, and volumetric imaging of the limbic system. There are many, many more that have been carried out by these interns. The work of the center is resulting in original scientific contribution that addresses key research questions important to the Indian context. It's also leading to the training and development of a critical mass of young research professionals. Over the last 5 years, the center has been teaching clinical components of the MS in Neurosciences course of Faculty of Medicine, Madras University. 4 batches of interdisciplinary professionals in the neurosciences have now graduated through this program. I'm delighted to inform you that in this academic year, the center was inspected by the Tamil Nadu Dr. MGR Medical University and passed the inspection with flying colors, and therefore has now been affiliated with this prestigious institution for offering PhD courses in neuropsychiatry, disability, and medical neuroscience. That the center will be launching this PhD effort with a full complement of 12 PhD fellows in its inaugural year is in itself testimony to the excellent research work that is going on and to the rigorous academic climate the center has engendered over the years. I am delighted that the Vice Chancellor has invited the center to launch the postgraduate program in neurological sciences. These are giant steps for a small community hospital and demonstrate amply the strength of NGOs, particularly or popularly referred to as the third sector in national development. The TS Srinivasan Center at the Institute of Neurological Sciences, VHS Hospital, exemplifies the important role that NGOs can play, not just in healthcare delivery, but also in teaching and research, taking cutting-edge development to the communities they serve. In the last academic year, the center has begun to take an active interest in development of evidence-based health policy for neurological and neuropsychiatric disorders, having identified this need in the Indian neurosciences arena. The effective use of the International Expert Consensus Development Approach in partnership with the International League Against Epilepsy, the Indian Epilepsy Association, and the Indian Epilepsy Society has led to a clinical and health policy paradigm called disabling epilepsy. Such work has the potential to inform and educate policymakers about key areas that require cogent health policy development and implementation. The issue of neurolinks that is being released today has the details of these deliberations and provide an important reference point in this area. I am very pleased about many milestones the members of this group have achieved in their personal capacity over the last year. I would like to take this opportunity to commend the center, particularly the leadership of Dr. E.S. Krishnamurthy and his team, for the excellent work that they are doing, and I wish them well in their endeavors. The center in this academic year, with the leadership of the National Brain Research Center in Manesar, taking an active part in the developing a national research program on brain aging and cognitive decline. Progressive loss of brain and mind function occurs in many elders, with memory of recent events being lost and changes in behavior occurring. Brain functions such as language, arithmetic ability, and social judgment are impaired, and the personality as a whole changes. Indeed, the human condition is so badly affected that dementia has been described as a fate worse than death. Dementia is clearly linked with aging. The longer one lives, the more one is likely to develop it. Many years ago, when we had lecturers, the common refrain from the audience used to be, that is Alzheimer's or dementia, a particular Western syndrome, as we do not find it common in India. But with India also aging, and as Dr. Krishnamurthy said, along with China, there will be many, many more cases of dementia. There are 24 million worldwide today, but India has a small share of it, but one day will come to have a significant share of it. While dementia has received much attention in the developed world, unfortunately few recognize it in India, and particularly when you go to rural communities, few are able to diagnose it. It is estimated that by 2020, as has already been said, 5 nations with elderly populations will be developing, with China and India topping the list. And the care of these elderly becomes a very significant issue, and it needs to take its due share of responsibility in dealing with our aging population. As India becomes more nuclear in its families, as people migrate from the towns or villages where they were born to work in cities far away, both within and outside India, the care of these elderly will fall upon social institutions which are sponsored by the government and cannot depend only on the family. We therefore must develop this with a sense of urgency, a plan for the care of these elderly people. We must also have a national research program examining both factors that cause and protect against the brain and mind disability in the elderly. Only focused research efforts at the national scope have the potential to provide tangible answers and the potential to influence health policy both nationally and internationally. I am really pleased that the TS Srinivasan Center and NBRC have organized workshops in Chennai and Delhi with the mentorship of the TS Srinivasan visiting professors, Professor Morris, Professor Sangram Sisodia, both of whom are here in Chennai today, and Professor Mary Ganguly would be joining us in Delhi. I wish that this concerted effort taking place with Professor Vijay Lakshmi, Director of NBRC, at the helm of all success. Finally, I have the pleasant duty of introducing the lecturer for the year, the 29th TS Srinivasan Endowment Orator, Professor John C. Morris. Dr. Morris received his BA from Ohio Wesleyan University. After receiving his MD from University of Rochester School of Medicine and Dentistry in New York, he completed his internship at San Francisco before joining a private practice as a family physician in Fairbanks, Alaska, and then directing the emergency rooms at Carlsbad Center in New Mexico. I wonder whether the cold made you, in those days, go away to such a warm climate. Dr. Morris received board certification in internal medicine and neurology after returning to Ohio to complete residency programs in medicine and neurology. He joined Washington University School of Medicine in '82 as postdoctoral fellow in neuropharmacology and as an instructor in neurology in '83. He was named as the Harvey A. and Doris May Hacker Friedman Professor of Neurology in 1998 and Distinguished Professor in 2003. He is in addition Professor of Pathology and Immunology, Professor of Physical Therapy, and Director of the Memory and Aging Project and the Center for Aging at Washington University. He is also the Director and Principal Investigator of the Alzheimer's Disease Research Center. Dr. Morris is the Principal Investigator of 2 program projects, Healthy Aging and Senile Dementia, and Antecedent Biomarkers for AD, the Adult Children's Study, and Alzheimer's Disease Research Center, all funded by the National Institute on Aging. He directs Washington University's Harvey A. Friedman Center for Aging. In the Medical School's Department of Neurology, Dr. Morris serves as the head of Dementia and Aging section. He has over 250 publications to his credit and has edited the first and second editions of the Handbook of Dementing Illness. He has received many honors, including Lifetime Achievement Award from the Alzheimer's Association in 2004 and the Potemkin Prize for Research in PICS, Alzheimer's, and related diseases from the American Academy of Neurology in 2005. I have great pleasure in presenting him with the TS Srinivasan Gold Medal and Scroll and in inviting him to deliver the 29th TS Srinivasan Endowment Lecture. But most of all, I would like to thank him and all his predecessors who have really contributed so much to the growth of neurology and understanding of neurology in a country which is not only poor, but unfortunately now aging as well. Thank you very much.
I would now request Professor Morris to deliver the 29th TS Srinivasan Endowment Oration. Thank you.
Honor for me to be the 29th Srinivasan Oration presenter. I have had a wonderful visit to Chennai, and I very much appreciated the hospitality that has been extended to me. I have been told that a previous orator fainted during the presentation. I hope not to do that, and I successfully didn't fall, so maybe we're off to a good start here. I would like to thank Dr. E.S. Krishnamurthy, the TS Srinivasan Chair of Clinical Neurosciences, who made the invitation and allowed me to come to present. Mr. Srinivasan, in his remarks, very appropriately mentioned that there are two areas that we must always approach when we're talking about elderly people and their illnesses. One, on the psychosocial side, the care for them, and two, on the research side, trying to understand the causes and develop therapies. Krish is very much an expert on the psychosocial side and has devoted much of his research effort to building up those programs. And of course, his father, Dr. Srinivas, has been a delight to get to meet and interact with since I have been here. And I've already learned a great deal of neurological history, and it's been just wonderful. And some of you know that he has devoted his life to the mission of caring for people, including people who cannot afford medical care. And he is really a person who lives up to the statement attributed to Mahatma Gandhi that we can double our joys by endeavoring to have the sorrows of others. So it's been a great privilege for me to meet him. And then finally, the TS Srinivasan Charitable Trust, the Center for Clinical Neurosciences that they support, and the family. It's just been a real honor to be able to interact with them. Well, at Washington University in St. Louis, we have an Alzheimer's Disease Research Center. As I said, there are these two major areas we must discuss when we're talking about the elderly, the psychosocial care and the research. And I'm going to focus my remarks primarily on the research side. And this is the team of individuals whom I have the privilege to direct at our research center in Washington University. And I list them here only because the research work that I will present has been done largely by them. When we're talking about aging, we often focus on the illnesses of aging. It's important to recognize that there are many aging individuals who do very well. They live long and productive and happy lives. I show this photograph of one of our volunteers in our research program on the occasion of her 100th birthday. And you can, I think, easily tell that she is one of the individuals who has escaped many of the illnesses, including dementia. She is mentally alert, and she's vibrant and active and integrated into life. So this is what we all should aspire to live a long life and keep all of our mental abilities intact. It is possible to do that, but how we can guarantee that for all of us is the question. So on the other side of healthy aging is aging in which mental faculties are eroded, and we call this dementia. Dementia has a definition. This is the definition, that areas of reasoning or memory, at least two of those areas, are impaired, and they're impaired so the individual no longer can carry out his or her daily life to the level that they once were able to do it. They have declined in their ability to carry out daily function because of this loss of mental ability. And it's important always to understand that we all have different abilities. We're born with different strengths, and we're trained or educated in different areas. So it's important to understand how a person has declined in relation to what he or she once was doing, not in comparison to how other people are doing. So the principle of intra-individual decline. Now, in developing countries, I am aware that there are problems in initiating research programs in dementia, particularly in Asian countries. There is a great respect for elders, and it may be difficult for family members to report that their parent is declining in terms of their ability to do their daily functioning, because in that way they may stigmatize them as having an illness, or they may believe that that decline is part of the aging process. It is not. Normal aging does not have this decline of the ability to perform your daily activities. So that's a barrier. How can we report older person's decline if if the family does not wish to do that, or they think it's just part of the aging process? Second, in developing countries, of course, there are many other needy illnesses, including communicable or infectious diseases, and so the emphasis and the funding may go or focus on those rather than these chronic illnesses. There may be other barriers to having individuals participate in research, including differences between traditional medical beliefs versus Western beliefs. Illiteracy is a major problem, and poverty, because it may be difficult for people to get care, much less to participate in research. And finally, at this point, we do not have truly effective therapies, so there's little incentive for people to participate in research. But I think there is great value in conducting research in India and in other countries. I show here a report from a study done in a rural community in India about how many people in each age group, shown here from 65 to 74, from 75 to 84, and from 85 and beyond, develop dementia each year. It's a funny term called incidence and rates per 1,000 person years, but you can see in comparison with this rural area of India, a comparison group of a rural area in the United States, and at every age level, the frequency, the development of Alzheimer's disease is much higher, about between 2 and 6 times higher in the United States. So a lower frequency of dementia in India. So the question would be, why? Why does it differ? So you have heard already that there is a growing imperative to study aging in developing countries, primarily because of the numbers. Much of the world's aging population already is in developing countries, at least 60%. And of course, that's going to grow. The Indian subcontinent alone now has 1/6 of the world's population overall, and will have 15% of the world's population age 60 and over in just 11 years. And studying the frequency of dementia in different populations, I think, is very important because it may help us understand what may protect one group of individuals or put another group of individuals at risk, and this will give us information about the causes of this illness. So the presence of dementia in at least one segment of the Indian population is the lowest recorded. And why should that be? Does it have to do with dietary factors, with other health practices, with genetic inheritance? Unless we study this, we won't know, we won't understand, so we need to double our efforts in research. And this graph shows that over the next several years, the frequency of dementia worldwide is going to increase almost exponentially. A huge number of older people are going to develop dementia. And you notice the most developed countries doesn't change nearly so much. This worldwide explosion of dementia is going to will be related to the fact of the less developed countries. It's going to really increase. So it's a coming epidemic in the less developed countries, including India. That's going to drive the dementia occurrence. In the United States, I think it already is an epidemic. It has a terrible impact upon the individual because they lose their capacity to be their normal human self. They lose their power of reasoning, they lose their memory, they lose their ability to care for themselves, and it takes a terrific toll on the family who has to care for the individual. It's very expensive to provide this care. So we need to address this as a serious illness. Once again, not part of normal aging. This is an illness. It shortens life, and it causes a tremendous toll on both the individual and the family. I thought I might show you one person's anguish in developing Alzheimer's disease. It happens to be a visual artist, a painter, a man named William Utermohlen, who lived from 1993 to 2007. Although he was born in the United States, he did almost all of his artistic work in London. He was diagnosed there with Alzheimer's disease in 1995 at a relatively early age, at age 62. Now, his work has been reviewed and collected by an American pharmaceutical firm called Myriad Pharmaceuticals, and they should have credit for what I'm about to show you. So as a young man, here was a pencil self-portrait done by Utermohlen. You'd notice that he has sort of a characteristic that we'll see in some later self-portraits where he displays his face sort of asymmetrically, and he makes, for whatever reason, he makes his right ear become very prominent. So he went off to London and had a very productive artistic life and married an art historian. But in 1995 is when he was given the diagnosis of dementia. And I think this next portrait is a self-portrait. And I think it looks very stark to me. So he shows himself in an empty studio, and perhaps this was his last major painting. And here it is. It's called Blue Skies. And you see him sitting at a desk, or a table, almost as if he's holding on. And he looks very distraught and very disappointed and very afraid. And it's almost as if through the open window he sees his future as the emptiness of this blue sky above him. And then he did no further large paintings, but he did do several self-portraits. Here's one when he was about 2 years into his illness. It's a self-portrait that you may be able to make out. Here is a saw. He was just told that day that the only way to confirm the diagnosis of Alzheimer's disease is by autopsy. So I think the inclusion of the saw is somewhat his, and we see sort of an anguish on his face about what is in store for him. Then a little bit later, another self-portrait, and here he looks, to me, looks sad and resigned about his fate. Once again, there's that sort of that asymmetry of his face, and there's that prominent right ear. And then here is his final painting in the last stages of his illness. He no longer could write his name at this point. He tried to give the eyes, I think we see the outline of that right ear, but he ended up trying to erase it, so he was unable to complete this. So I think we've seen here sort of a psychological scrutiny of an intense personal experience of progressing through the stages of dementia. And we get something of the emotional devastation that people go through as they have this illness. Well, this again shows that Alzheimer's disease, as we've already heard, is very much age-related. The older we are, the more likely we are to develop Alzheimer's disease. These are information, data from the United States. It says that there's very few people who have Alzheimer's disease below the age of 65, but once it reaches 65, it increases dramatically. Matter of fact, in this particular depiction, for every 5 years of age after age 65, the frequency of developing Alzheimer's disease doubles. So if we say something like 5% of the people at age 65 have Alzheimer's disease, at age 70 it's 10%, at age 75 it's 20%, and so forth until age 85, 50% of people age 85 have Alzheimer's disease. Tremendous number association with age. The older we are, the more likely we are to develop this illness. There are also genetic factors, and these vary widely among individuals and among populations. Once again, to understand them, we need to include many populations to understand how each one might provide both risk for developing the disease, because Alzheimer's disease does run in families, but also potential protective factors. Perhaps we can inherit a genetic profile from our family that enables us to live without developing it. Well, we can't do much about age. We can't do much about the genetic profile that our parents have given us. But there are other risk factors for developing dementia that perhaps we can do something about, can modify. And one of the most important is the vascular risk factors, particularly heart health. So things that even in middle age that occur to us from our heart health that may influence whether we develop dementia and Alzheimer's disease decades later. Another potentially modifiable risk factor are these psychosocial factors or lifestyle factors, how we maintain our lives and whether that helps us ward off the potential onset of dementia. Under vascular factors are things you know well, high blood pressure, hypertension, obesity, diabetes, high cholesterol, high lipids, having heart disease, and having strokes. All of these have been associated in late life with a greater risk of having Alzheimer's disease. All of these are potentially preventable. We can control blood pressure. We control cholesterol. We can do something about this. So if this really is a factor, then this is one area that we might explore to try to reduce the risk of Alzheimer's. And dietary factors, I think, aren't examined quite enough. Unfortunately, in the United States, the things that taste really good are the things that are bad for us. But what we have found that there are certain diets that seem to be associated with a reduced risk of developing Alzheimer's, including fish and fruits and vegetables, light to moderate alcohol consumption, and antioxidants. And there's great interest in example for curcumin as a potential treatment for Alzheimer's. By the way, resveratrol is an ingredient found in in red wine, and may be the reason why red wine seems to have some protective factor. And here are the psychosocial factors. Basically what these indicate is remaining thoroughly engaged, so physically active, mentally engaged, and socially connected. All of these have been associated with reduced risk of developing dementia. Now, we've heard a little bit about the clinical dementia rating. I certainly don't want to belabor that. We call it, for short, the CDR. But again, the emphasis on the CDR is simply to assess this principle of whether the person has declined in his or her mental ability so that they can carry out their usual functions. If they cannot, then the CDR is able to capture that at an early stage and help us determine whether someone is demented, and if so, to what severity. And this is just a sort of a grid that shows the clinical dementia rating. And again, I don't want to belabor this, but I'll be happy to address any questions should there be any. We have some treatments now approved in the United States for people who have dementia that is caused by Alzheimer's disease. And in late life, I think by far the leading cause of dementia, this loss of memory and thinking ability, is Alzheimer's disease. It's not the only cause, but in late life it is by far the leading cause. And these are the current drugs that are available to treat mild to moderate Alzheimer's disease. I think they work, I think they help, but they help only to a very small degree. They are by no means are as effective as we would like, and by no means do they recommend cures. So we use them because that's all we have available, but we certainly need more powerful and more effective therapies. So how are we going to do that? I think we have to return to the idea of what are the causes of Alzheimer's disease. So here I've shown an old image from Professor Alzheimer of his original patient, a woman who developed dementia at age 51 and died at age 55. Professor Alzheimer retrieved her brain, did an autopsy, and under the microscope found what we now call senile plaques, shown here, and neurofibrillary tangles. We see a more modern depiction of the plaques and tangles here, but the plaques and tangles are simply hallmarks that the brain cells are dying. That's the bottom line in Alzheimer's disease. Brain cells die, they're lost. And so not surprisingly, the brain of an Alzheimer patient is much smaller, it's shrunken in comparison with a healthy person of the same age. You can see that the amount of brain tissue is much less, the fluid spaces are much wider. The brain is smaller because brain cells are lost. So why are they lost? Well, maybe we can come back to these hallmark lesions and try to understand them, and we've done a great deal of work in this area in the past 2 decades. Professor Sisodia and his team have contributed greatly to the understanding of this. We know now that the plaques are made up of an abnormal processed protein called amyloid, and the tangles include a protein called tau, so we can understand these proteins, and we can begin to think of how abnormalities of amyloid, here this is a symbol for amyloid, and here is tau, what the cascade is, what goes wrong first, and does that lead to the ultimate cause, which is cell death, cell loss. Is it this type of a model? Are they both working simultaneously? And we can begin to try to devise therapies to address both of those models. And we have many compounds now, in 2009, that are in the clinic being tested. Some address amyloid, some address tau, some try to restore the brain cell health, including potentially stem cell therapies and many more possible therapies. But they must be tested. We must, if we want to really develop truly effective therapies, we must commit ourselves to testing and evaluating these drugs to find out which provide benefit and which may be safe. We need drugs that are effective, but also that are safe as well. And some of you may have been here when Professor Jeffrey Cummings from UCLA was the TS Srinivasan Oration presenter, and I point that out as well. Now, I just want to spend the final few moments of my remarks on a potential hypothesis about the origins of Alzheimer's disease. And this has both a very profound and potentially negative side, but also ultimately, I hope, a potentially very positive side. So what this diagram shows, and this is hypothesis, is this white line marks the onset of the symptoms of Alzheimer's disease. That is the onset of dementia, which is how we diagnose Alzheimer's disease, when dementia occurs. And what this says is when we make the diagnosis, it may be too late. Work from our group at Washington University and others has shown that at this very stage, just when we physicians, neurologists, and old age psychiatrists and geriatricians make the diagnosis, we know that already in certain areas of the brain that are particularly vulnerable to the Alzheimer process, already up to 60% of the brain cells have been lost. So if we introduce treatment here, which is, of course, the only time we start therapy is when we make the diagnosis, it's too late. The brain is already badly damaged. So what we think may happen is that the plaques and the neurofibrillary tangles may begin many years before they build up and cause enough brain damage that the brain fails and the symptoms appear. What we would like to do is, if this is true, is to try to devise treatments that we'd introduce here before there is substantial brain cell loss. Well, we can't do that now because we can't diagnose it in this pre-symptomatic stage. So what we think we're going to need to do is to develop some tests for this stage. We call them biomarkers. And we call them biomarkers before the dementia occurs, so antecedent biomarkers. I really don't have time to go over this in detail. I will tell you that I think the future research in Alzheimer's disease is going to be in two major areas. One is biomarker development. Can we develop a test for the illness? And in drug therapies that attack the very processes of the disease in terms of the amyloid and the tau. There are many potential biomarkers. I call this preclinical Alzheimer's disease. That is, the Alzheimer process is in the brain, but there's no clinical detection. There's no symptoms yet, no dementia. So preclinical Alzheimer's. And there are many ways we can try to think about trying to look at changes that tell us that the brain process has already started, including assays of blood and spinal fluid. And I'm only going to mention here imaging strategies.